So the natural next question was, should we be thinking about utilizing this drug upfront in the early stage setting?
So we've seen a lot of data for the treatment of HER2 amplified breast cancer, both in the metastatic setting and now in the early stage setting. And I'd like to have a conversation with you about how we contextualize and even implement some of the recent data sets in the early stage setting. Why don't we start in the neoadjuvant setting, where we've seen the DESTINY-Breast11 trial, and looking at the question of whether we should be using an ADC regimen with trastuzumab deruxtecan and THP in the neoadjuvant setting versus standard of care, although we can have a discussion about the definition of standard of care. But Dr. Jhaveri, could you walk us through DESTINY-Breast11 and what struck you in terms of the results from that trial?
Yeah, no, absolutely. So I think, we've seen robust activity and robust efficacy, and we have approval for trastuzumab deruxtecan, obviously, in the metastatic setting. Both in the late-line metastatic setting, we saw data for T-DXd in patients with metastatic brain metastases as well in the DESTINY-Breast12 trial. More recently, we've seen the first-line metastatic study with DESTINY-Breast09, where again we saw an unprecedented progression-free survival benefit as well for T-DXd plus pertuzumab. So the natural next question was, should we be thinking about utilizing this drug upfront in the early stage setting, and would that lead to further improvement in outcomes or optimization of outcomes for our patient? So DESTINY-Breast11 is a neoadjuvant attempt where we had 3 arms. We had T-DXd monotherapy, which was administered for 8 cycles, so every 3 weeks, 1 cycle for 8 cycles. We had the combination of T-DXd with pertuzumab, and then we also had a sequential therapy after 4 cycles with THP. And the comparator arm really was for our high-risk patient population, an anthracycline taxane-based regimen with dual HER2 blockade, so ACTHP. The primary endpoint was to look at pathological complete response rates. And when historically we think about what do we expect with neoadjuvant therapies with HER2-positive breast cancer when it comes to PCR, I think we think about somewhere between 39 and 60%. And what we saw, at least right now, the IDMC really held the monotherapy cohort because I think the efficacy that they saw, the PCR rates that they saw did not necessarily were going to beat the ACTHP arm. And so that was something that they had shut down last year in 2024. But when we looked at the T-DXd followed by THP, that arm really yielded a PCR rate of 67%. And this included patients with hormone receptor positive and hormone receptor negative breast cancer. This was high-risk patient population, stage 2 and 3 breast cancers. And when we're talking about high risk, if you had a larger tumor size, so if you had a T3 tumor, you could even be node negative. You could certainly be node positive. If you are N1 to 3 nodal positivity, you could even have a smaller tumor size up to T1. So this is really your patient population that you see contemporarily in clinic.